Good morning, everyone, and welcome to Neurology Grand Rounds. This slide is up that has the code for your CME, but I'll go ahead and advance now on to introduce our CPC today. My name is Mary Dale Baggett. I'm a hospitalist here at Mass General, and I'm also one of the associate editors of the New England Journal of Medicine case records of the MGH. And I'm very happy to share with you one of my favorite MGH traditions today, which is the Clinicopathological Conference. So this is a long-standing tradition at MGH where we ask a primary discussant to discuss the case of a patient that was cared for at MGH without the benefit of the diagnosis, so that we have the opportunity to learn about their thought process and their diagnostic reasoning and how they would approach a patient in real time without the benefit of already knowing the diagnosis. And our primary discussant today is Dr. Aneesh Singhal, who's graciously agreed to discuss this case for us in the unknown format so that we can learn from him the most about this case. Dr. Singhal will be joined today by Dr. Silverman of neurology, Dr. Romero will be going over the imaging, and Dr. Lang-Orsini will discuss the pathology that's relevant towards the end of the case. So without any further delay, so that we have the most time possible, I'll ask Dr. Silverman to get us started telling us about this patient. Ooh, I'm sorry, Scott, I muted you instead of myself.
We're good. Thank you very much, Meredale. It's a real pleasure to be presenting this case to you, and let's get started. So this is a 68-year-old man who was admitted to this hospital because of worsening confusion. He has a history of hypertension, coronary artery disease, and atrial fibrillation. He had been on Coumadin for years, but discontinued 10 years before this admission. So 2 months prior to the MGH admission, he presented to an outside hospital with aphasia. He had an NIH SS score of 3. His initial head CT was negative. His CTA of the head and neck showed mild multifocal atherosclerotic disease. His MRI of his brain showed several small foci of restricted diffusion in both frontal lobes, posterior limb of the right internal capsule and right middle cerebellar peduncle. There was one small microhemorrhage in the left parietal white matter. At that point, the treating doctors at the outside hospital institution felt the stroke etiology was cardioembolic from atrial fibrillation. He was started on apixaban and aspirin and discharged home on the second hospital day. Unfortunately, 4 days later, he presented back to the same hospital with transient mild aphasia. The MRI was repeated, and this time there was no new infarcts. There was mention of moderate nonspecific white matter disease bilaterally in the periventricular and subcortical white matter. At the time of admission, his blood pressure was low, his systolics were less than 100, and his symptoms were felt to be attributed to either hypoperfusion or sequelae from prior strokes. His antihypertensives, amlodipine and lisinopril, were discontinued, and he was discharged home on the 4th hospital day. 3 weeks later, he presented again with confusion and lethargy. He was noted to have new urinary incontinence, an unsteady gait, and a withdrawn affect. MRI of his brain showed new areas of restricted diffusion bilaterally in the centrum semiovale and corona radiata. A CT of his chest, abdomen, pelvis was performed, and this was notable for a spiculated 1.7 centimeter mass in the left lower lobe of his lung and an exophytic hyperdense mass 1.6 centimeters in the left kidney. No changes were made at that time to his medications, and he was discharged to rehab with plans to follow up with local oncology. So he went to rehab, but unfortunately 3 days after he got out of rehab, he presented again with numbness and tingling in his right hand and arm. MRI was repeated and again showed new infarcts in the left thalamus, right frontal subcortical white matter, and left periventricular white matter without hemorrhage. There was notation of interval progression of T2 hyperintensities in both frontal lobes and to a lesser degree in the parietal lobes. And there were new flare and T2 hyperintensities in the right greater than left anterior temporal lobes bilaterally. Apixaban was discontinued and he was started on therapeutic enoxaparin. He was discharged home on the 3rd hospital day. Unfortunately, 5 days later, he presented to MGH with dysphagia, worsening confusion, aphasia, and balance. Going into his past medical history, it was notable for hypertension, hyperlipidemia, diabetes, and obesity. His medications on admission included enoxaparin, aspirin, atorvastatin, and metformin. He was a longtime smoker, having smoked for about 40 years, but recently had cut back. He had occasional marijuana use and rare alcohol use. His family history was significant in that his father had early coronary disease with an MI in the 4th decade of his life. Here are his admission vital signs. He was afebrile. His blood pressure was elevated at 158/75. Pulse was in the 70s. He was breathing fine on room air. His initial neurologic examination, he was noted to be alert and interactive. He was oriented, but had slowness to respond. His speech was fluent. No paraphasic errors were noted. He followed simple commands, but had some difficulty with more complex commands. He had an upper motor neuron right facial droop, a right pronator drift, and mild right hemiparesis. The rest of his neurologic exam was normal. Here are some of his admitting labs. His chemistry and liver function tests were normal. He was slightly anemic. Hemoglobin was 12.7. His white count and platelets were normal. His SED rate was 15. His D-dimer was elevated at 912. He had greater than 100 white blood cells in his UA. Lupus anticoagulant, cardiolipin antibodies, beta-2 glycoprotein antibodies were all negative. He had a positive ANA. Imaging studies were obtained. CTA of his head and neck showed mild multifocal atherosclerotic narrowing of the cervical and intracranial arteries. And his MRI showed numerous scattered small foci of restricted diffusion with extensive confluent periventricular and subcortical white matter T2 hyperintensities. Patient was admitted to MGH on the inpatient stroke service. He was started on intravenous heparin. He had an echocardiogram that showed no wall motion abnormalities, normal ejection fraction, normal left atrial size, no PFO, no mitral or aortic valve vegetations. Blood cultures were negative. A diagnosis and management decisions were made.
Thank you for the invitation. This is Javier Romero. Next slide, please. So here we have axial non-contrast CT scans at the level of the ventricles. And what we can see is this very confluent low attenuation along the periventricular white matter extending all the way until the subcortical white matter peripherally. These both images demonstrate the same pattern of low attenuation. Next slide, please. This is the CTA of the head demonstrating the intracranial circulation. And your left side, you can see the speckled calcification within the carotid siphons. However, these do not result in significant narrowing of the internal carotid arteries. The remainder of the intracranial circulations appears unremarkable with normal caliber of the vasculature and without any signs of vessel occlusion. Next slide, please. These are reformatted curve images of the vasculature of the neck. And here is focused on the right hand, or where it's mentioned right. Basically, the right common carotid artery and internal carotid artery demonstrates completely normal lumen. On the left-hand side, or left side, you can see a small focus of calcification within the bifurcation, but without significant narrowing of the vasculature. Next slide, please. This is the admission MRI, where we confirm these findings within the white matter, this confluent and high T2 signal intensity on FLAIR images on the top row. We can see that this is quite unusual, where we see the high signal extending from the periventricular white matter all the way up to the subcortical white matter, but respecting that, as you can see, the ribbon of the gray matter in the left-hand side. In the inferior row, we see two images of diffusion-weighted images. And as we can see here, we do see multiple foci of restricted diffusion, which appear bright on this sequence. And here in the globus pallidus on the left, periatrial white matter on the right. On the right-hand side, we see multiple linear, very classic images of restricted diffusion within the corona radiata and centrum semiovale. Next slide, please.
Good morning, everyone. Aneesh Singhal here. I'd like to first just thank Meridale and Eric Rosenberg, Emily McDonald, and Carol for their phenomenal job in inviting me and setting this up. And also Scott and Javier, and to follow me, Melanie, for their hard work in constructing the background, the imaging, and the pathology for this case. Thank you very much. Next slide. I'd like to begin by acknowledging the contributions of Dr. C. Miller Fisher, who was a giant of stroke medicine at our own institute, who passed away exactly 10 years ago on April 14th, 2012. So I'm really privileged to speak today and acknowledge the master of clinical pathological correlation, Dr. Fisher. Next slide. So as Scott mentioned, this is a 68-year-old man with cognitive decline, accumulating focal deficits, and small non-lacunar ischemic strokes. Javier was careful in pointing out the shape and size of those lesions. And progressive white matter change, mild CTA abnormalities, and a chest X-ray suggesting metastatic lung cancer. He had a variety of non-modifiable and modifiable risk factors, including atrial fibrillation untreated and the most common vascular risk factors, including hypertension, hyperlipidemia, diabetes, increased body mass index. Next slide. So how do we approach this case? I always start with the clinical approach and try and make sense of the presenting signs and symptoms, and then move on to considering mechanisms. The first admission was characterized by aphasia. We don't have much detail about the aphasia, but I'm not sure if it was a Broca's type or a Wernicke's type or what type of aphasia this was. There was also right hemianopia. Anyway, this clinical syndrome with aphasia and visual loss is typical for cardiac embolism. However, the imaging findings did not support it. So there was no clinical imaging correlation. The lesion topography was also atypical for embolism from atrial fibrillation. And looking at the literature, AFib typically causes one or sometimes a couple of relatively large and wedge-shaped infarcts affecting the cortex and subcortex. And there's frequent post-ischemic hemorrhage, none of which was present in our patient. In the second admission, just a few days later, he came in again with what they thought was transient aphasia, not otherwise specified. This was probably a TIA, but the team appropriately thought that this may have been hypertension or attributed to sequelae of prior strokes. This is a term that's been used for decades called recrudescence. Not much is known about that, but I had an opportunity, next slide, to study this for the first time. And we found that recrudescence typically occurs about 4 years after the stroke. It lasts for about a day mostly. And the NIH stroke scale score worsening is quite mild, only about 2.5 points. We identified triggers such as infection, hypotension, hyponatremia, insomnia, or benzodiazepine use. And in this patient, hypertension may have been a possible trigger, but he did not have infection or hyponatremia, which are much more common. So I think overall recrudescence was possible, but this may also have been a TIA. Next. The third admission, the patient came in with confusion and a withdrawn affect. So really the predominant progression was cognitive change. And superimposed on that were focal deficits. Now, the next time he had brain imaging, it showed new bihemispheric small ischemic brain lesions. So how do you put this together clinically? A common classification for clinical stroke syndromes is the Oxfordshire Community Stroke Project classification, or the OCSP. And they have described the PACI and TACI, which are the total and partial anterior circulation stroke syndromes, where you need to have hemianopia, and it's really a very focal, well-defined syndrome, typically affecting the MCAs. This patient's syndrome did not fit the anterior circulation syndrome. We know that the cognitive change and everything else did not constitute a lacunar stroke syndrome, so that's out, LACS, and there weren't any significant posterior circulation findings. So it's hard to fit what seems to be stroke, accumulating stroke deficits into any clinical stroke syndrome. I've been interested in this phenomenon, and I've looked into conditions that cause encephalopathy, which is hard to define as MCA or PC or basilar territory stroke, for example, from multifocal infarcts. And we found that they were relevant to conditions such as endocarditis, either subacute bacterial endocarditis or non-bacterial thrombotic endocarditis, where global encephalopathy is pretty common as a presenting symptom. Vasculitis, or primary angiitis of the central nervous system, PACNS, is notorious for this cognitive change with some focal deficits. And of course, other conditions such as TTP-HUS, and in today's day and age, we must always consider COVID-19 as a contributing factor. So again, I really thought we were dealing with the worsening encephalopathy from multifocal infarcts. Next. The next admission, he had focal deficits, but worsening cognition. And again, there was progression of the imaging findings. Now, when you start stepping back, it is my habit to pay close attention to imaging infarct lesion pattern distribution or infarct topography. Now, studies have found some conflicting evidence, and there's been a variable association with stroke mechanism. But consistently, we find that multi-territory bilateral strokes are most often cardioembolic. But when you look into the details, those are usually larger, wedge-shaped, a little more distal in the arterial tree than what we're finding in our case. So in our patient, the small lesion size and distribution is not entirely consistent, and certainly not with atrial fibrillation, in my opinion, despite the patient's untreated atrial fibrillation. Frequent recurrences within 4 weeks is also atypical for the most common conditions that cause stroke, such as AFib and atherosclerosis, and especially in a patient who is now being treated. So again, I think we have to step back and think that this is something unusual. Next. Many years ago from Mass General, we proposed the causative classification of stroke schema, which is really the TOAST classification, but with well-defined definitions of each. Again, as looking back, I think cardiac embolism, mainly atrial fibrillation, seems unlikely. Other causes of cardiac embolism have not yet been ruled out. Large artery atherosclerosis also seems unlikely, especially given Javier's demonstration of calcification without significant stenosis. However, microvascular disease may be possible. Small vessel disease, as in the well-defined lacunar stroke syndromes, again seems unlikely. So when we look back, we're thinking about something that's unusual, but perhaps well-defined, as in bacterial endocarditis, vasculitis, cancer, or a less defined mechanism because of competing mechanisms. It's important to now factor in the actual lesion location. And I find it very interesting to note that in our patient, the peduncle, the forceps minor were all involved, and these lesions were kind of radial in nature. So I think these are important considerations. Next. When you think about multifocal small lesions, we come across, I think that when you look at the mimics of primary angiitis of the central nervous system, it's really the same differential diagnosis, including intracranial athero, lymphoproliferative disorders or intravascular lymphoma, genetic conditions in younger adults, rheumatological conditions which can cause systemic vasculitis and a secondary affliction of the brain, infections, and finally, embolic strokes from the heart or aorta. Next slide, please. So I'm now going to walk you through my differential diagnosis based upon everything I've just said. And I'm going to classify it as, could this be an atypical embolism from the heart or aorta? Or can this be something within the brain itself, within the brain arteries? And the conditions are mentioned here. I'm going to go through each one and discuss why or why not we should consider that. Not to forget that overarching behind all of this is the contribution of what seems to be advanced lung cancer as evidenced by the abnormal chest X-ray and the kidney lesion. Next. Before we start getting into the details of each, we should look at the natural history of such conditions. So for intracranial atherosclerosis, the recurrent stroke or death rate is 10.7% at 30 days, 25% at a year. Across different trials, there were different recurrence rates, but generally it's high, but not as high as we're seeing in our patient. With embolic strokes of uncertain mechanism, it's about 3 to 6%. With subacute bacterial endocarditis, it's very high if untreated. But in treated endocarditis, after about a week, it falls down to baseline rates of about 1 per 1,000 patient days. Patients with cancer can have 15% chances of recurrence, but their survival is limited. You don't have that much data about recurrent stroke rates. Primary angiitis of the central nervous system can have variable stroke recurrent rates, and the Mayo Clinic series has described rather a very rapidly progressive change as well. The average works out to about 25% over 6 to 9 months. Next. So let's start with the embolic mechanisms such as endocarditis. Again, for many reasons, I don't really think it is any of these, but I'm going to go through the steps. Next. So a few years ago, we looked into endocarditis lesion patterns, and with bacterial endocarditis, the most common patterns are to have a single or a territorial infarct, pattern 1 and 2. But then the most common is pattern 3, which is disseminated small infarcts, which accounted for about half the patients. Now focus on pattern 3, and you'll note that the small tiny lesions are both above and below the tentorium. They affect both sides, left and right, but the lesions are a little more distal and more rounded than the linear shape that we're seeing in our patient. So I really don't think infective endocarditis is likely, particularly given the low SED rate, the negative echo, and the negative blood cultures. Next. The patient has cancer, so could he have had a non-bacterial vegetation? Well, over there, I think the uniform pattern in every patient that we studied was large and small strokes, the large being defined as at least 3 centimeters in axial diameter. And as you can see, our patient did not have that. Nevertheless, cancer is common. It affects about 39% of people over their lifetime. Cancer-associated hypercoagulability causes the release of mucins that activate platelets and endothelial cells, culminating in these very fragile vegetations that when they embolize, they shower and they cause these very large volume strokes all over the brain. NBTE, of course, cannot be ruled out with the negative transthoracic echo. And 50% of them end up being classified as ESUS, only to be identified later on the patient's autopsy. Furthermore, in cancer-associated stroke with NBTE, the D-dimer levels are typically very high, and in our patient, we're only 912. But D-dimer levels above about 2,500 to 3,000 would be predictive of cancer as the cause of the patient's stroke. Next. An unusual condition is atrial myxoma. Again, the lesions, as you can see from this image, are really quite distal. They have a waxy appearance on T2 and flare. And again, the pattern does not seem consistent. The low SED rate, again, almost always rules out cardiac myxoma. Next. So in conclusion, embolic mechanism is, in my opinion, highly unlikely for the factors listed on this slide, including the normal SED rate, negative blood cultures, the negative antiphospholipid antibody panel, and so on. The high recurrent stroke rate may perhaps be explained by other mechanisms. So let's look into those. Next. So again, going back to my list of differential diagnoses, patient with small multifocal recurrent infarcts. Could this be a combination of not the medium-sized arteries, which don't have significant stenosis, but more distal atherosclerosis combined with cancer-related hypercoagulability? Individually, I think athero is unlikely, cancer-associated is unlikely, but the patient has both. So could this be a two-factor issue? Next. So cancer-associated stroke, which is, by the way, different from non-bacterial thrombotic endocarditis, where you need to have vegetations documented. This is cancer-associated stroke because of hypercoagulability. It has an incidence of about 10%, and in patients with cancer, the first manifestation happens to be stroke in about 5%, and that frequency is higher in younger individuals, about 7.5%. Multiple studies have shown that lung cancer, cancers like adenocarcinomas of the GI tract and breast, are most likely to be associated with cancer-associated stroke. Biomarkers that predict include the elevated D-dimer, as stated above, about 2,500 nanograms per ml, elevated fibrinogen, C-reactive protein, also multi-infarct lesion topography, these larger strokes that I showed you in an earlier slide. Importantly, studies have shown that cancer-associated inflammation may worsen underlying atherosclerosis, and that's why I think it's important to consider cancer with athero in our patient. However, and I haven't really seen, and there's no literature describing that many infarcts in 4 weeks. Moreover, the patient had rather impressive progressive white matter changes, which would not be explained by discrete infarcts going up to the brain. Next. Moving on, the patient did not manifest any fever or other symptoms of any infection. There was no known HIV, tuberculosis, or syphilis exposure. Varicella zoster virus is a frequent mimic of primary angiitis of the CSF. And unless VZV is excluded by serologies, I think it's always difficult to rule that out definitively. Be that as it may, I'm not sure that this patient's such frequent strokes would be consistent in the absence of fever, elevated sed rate, white count with any of these infections. What about COVID-19? Well, the patient has strokes and white matter lesions. And I think there have been so many studies over the past 2 years since COVID broke out. We know that COVID frequently causes strokes with white matter change. So should that be considered in our patient? Next. 2 years ago, I had the privilege of doing the CPC on one of the first patients with COVID and stroke at Mass General. And thank you again, Meridale and Eric. And there we proposed several mechanisms, the most important one being cardiac embolism and coagulopathy with large artery embolic strokes. Small vessel infarcts, which is highly suspected in our patient, were the least common. And there's a lot of controversy about COVID causing an endothelitis or a vasculitis per se, whether it's a direct or indirect effect. In any event, in patients with COVID, stroke is typically a late manifestation. It is rarely the first manifestation, and it predicts a very poor outcome. In our patient, there's no mention of COVID testing being negative, but I suspect it was. And anyway, the infarct pattern does not really fit with COVID. Next. A variety of genetic disorders have been described, and as you can imagine, these are much more common in young children, adolescents, and not so common in adults. The more frequent ones are listed over here, CADASIL being the most common monogenetic disorder associated with stroke. I thought about it in our patient, but I think to have such rapid progression at age 68 would make genetic disorders highly unlikely. Next. CADASIL, as many of you know, is the cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, the acronym being CADASIL. This is an inherited condition which may be relevant given our patient's father having had a stroke in his 40s. It results from the mutation in Notch3. There's most often a history of migraine with aura, which was absent in our patient. There's very progressive over decades mood disturbances and dementia. There are small vessel infarcts as well as microbleeds. Anand Viswanathan in our center is a world expert on this. The diagnosis rests upon the very typical MRI findings of the anterior temporal lobe and external capsule white matter changes, which were not the case in our patient. And the more definitive diagnosis by biopsy and genetic testing. So I think we can safely rule out CADASIL and pretty much the other genetic conditions causing small vessel stroke. Next. So we're now left with this issue of inflammatory arteriopathies affecting the brain. And they can be classified as systemic with secondary brain involvement, such as what we see with Behçet's disease, systemic lupus, or sarcoid. And then primary angiitis of the CNS, where there's inflammatory arteritis restricted to the brain and spinal cord. And of course, an important mimic, intravascular CNS lymphoma. Next. So with systemic vasculitis, although this should be considered, our patient did not manifest any systemic symptom. The lab test results were not supportive, except perhaps the speckle pattern of 1:160 titer of ANA, which is not very specific. All the other blood tests and symptomatology did not support systemic vasculitis, and hence I would consider this unlikely. Next. Intravascular lymphoma can never be excluded in the absence of a brain biopsy, in my opinion, or at least CSF cytology. This condition is characterized by accumulating headaches, again, punctate infarctions with CSF abnormalities, and the diagnosis can be made with CSF and brain biopsy. But in the absence of CSF data in our patient and a brain biopsy as yet, I don't think we can exclude intravascular lymphoma. This is a rare condition, so let's keep this at the bottom of our list for now. Next. We're left with primary angiitis of the central nervous system. Next. This is a poorly understood inflammatory condition exclusively affecting the brain and spinal cord. It's rare. The Mayo Clinic data suggests an incidence of 2.4 cases per 1 million patient years. When it was first described in the 50s and for the few decades thereafter, it was viewed as a uniformly fatal condition requiring aggressive immune suppressive treatment. But more recent literature from our center, from Cleveland Clinic and the Mayo Clinic series and the French cohort have suggested that PSCNS is a heterogeneous condition. It can be treated and immune suppression can be stopped if it's detected early enough. Most patients come in with insidious dull aching headaches, which was absent in our patient. They have multifocal deficits, and a chronic meningitis encephalopathy is actually very common. Next. In 1988, Calabrese and Malik proposed diagnostic criteria, which were rather broad, but very practical. Presence of an acquired, otherwise unexplained deficit, classic angiographic, which by the way does not really exist. There's no classic angiographic pattern as we know today, but in 1988, this was fair, or histopathological features of angiitis, and nothing to explain inflammation outside of the brain. I think that's what they call PSCNS. In my experience, it is important to beware of mimics, unless you can only call a patient as having PSCNS if it's biopsy proven, or in the absence of pathology, if there's an abnormality on CTA or DSA with abnormal CSF and no infection, or if the clinical imaging features and CSF and everything is highly suggestive, and there's really, and you've also got expert opinion. So the diagnosis can be pretty challenging in the absence of a brain biopsy. Next. Now, cohort studies, I'm just showing you this data to get back to our case. He did not have headache, but headache is seen in 60% in this Mayo Clinic, which is the world's largest series to date. Cognitive dysfunction our patient had, seen in 54% of patients. And going back that spell of aphasia, we don't have any details, but aphasia is not that common as the first manifestation of PACNS. So I'm wondering whether the aphasia was more this sort of confusion, since we don't have any details about it. Next. That was the Mayo Clinic series, but data from the French COVAC cohort study also shows that headaches are about half the time, cognitive change is common. Abnormal CSF, we don't have results in our patient as yet, about 70%. And in our own series from Mass General, 47 patients, we found that this was male predominant and headaches were seen in about half the patients, and the CSF was abnormal in about 74% of patients. But notice here that we also looked at the infarct topography, and we found that 100% of patients with PSCNS had an MRI lesion. 80% of those were infarcts, the rest were white matter changes, I'll show you, and multiple infarcts were common. Next. So here are the lesion patterns. Again, the most important ones are disseminated small acute infarcts. This is very typical, and I think is quite consistent with the strokes we're seeing in our own patient, where you involve the cerebral peduncles, the forceps minor in other cases. Acute and chronic infarcts with underlying white matter change is extremely common. And of course, there are other lesion patterns as well, not applicable to our case. Next. We don't have results of advanced MRI. I think the team may want to consider that. This is a relatively new imaging tool that, in my opinion, is useful to support the diagnosis. You can't make a diagnosis of arteriopathy or arthritis on imaging, but you can use that as evidence to support. And in my opinion, it's a very good tool to follow patients and assess response to treatment. Next. There are many pathological subtypes of PSCNS, granulomatous, lymphocytic, necrotizing, A beta, and it can also come in as a solitary mass lesion. There's no clear clinical correlate. We have to be careful to rule out varicella zoster, which often causes granulomatous angioitis as well. Next. And the management, as I said, is with aggressive immune suppression. And today we find that 80%, especially those with gadolinium positive MRI scans, do respond to immune suppression. Relapses are common, and patients with cognitive change, perhaps relevant to our case, have poorer outcome. Next. So I think PSCNS seems plausible, as we can't rule out vascular lymphoma, for instance, but what about the elephant in the room? This is a picture taken by my brother-in-law on a trip to Botswana, where the hyenas were attacking the baby elephants in the background and the mother was stomping out the others. So this is the elephant in the room, and in our case, it's the presence of cancer. Next. So the patient has probably advanced lung cancer, and I went through the literature. There are a smattering of case reports and case series describing either giant cell arteritis, as I've shown here in red, with extracranial arterial involvement, or intracranial involvement with conditions such as Castleman syndrome, Hodgkin's disease. I think Scott and I had seen a patient with lymphoma and what we thought was paraneoplastic vasculitis. Now, not much is known about this entity, as I'm showing you most of the case reports that have been published. Next. I could find very few reports where pathology was actually documented, and this is a recent one from the journal Neurology, where the histopathological examination showed vasculitis, but surrounded by tumor cells. So there was some element of inflammation, but the tumor cells were surrounding the artery, suggesting that this was a paraneoplastic problem. Next slide. And those authors proposed a few mechanisms, including immune reactions or molecular mimicry, direct endothelial injury due to release of pro-inflammatory cytokines, deposition of tumor proteins with hypersensitivity, or immune complex deposition. It's not clear as to which of these mechanisms is true. Next. But in conclusion, I believe our patient had small vessel infarcts from an arteriopathy. Most likely, this was inflammatory based upon the progressive course, symptoms, and the infarct topography, and most importantly, progressive white matter change. The lung cancer was probably contributory from a paraneoplastic mechanism. And it's possible that chronic intracranial athero, as evidenced by the admission scan showing white matter change and the calcifications, it may have lowered the threshold from stroke from cancer hypercoagulability or an inflammatory arteriopathy. Next. This is my final slide. So in conclusion, I believe the patient had thrombotic infarcts from a paraneoplastic cerebral vasculitis, paraneoplastic from lung cancer, and there was a minor contribution from underlying atherosclerosis. I would propose a biopsy of the lung or the renal mass, a CSF examination, including cytology and VZV, an advanced vessel wall MRI to see if there's any enhancement of the intracranial arteries, and if necessary, after all these tests, a targeted brain biopsy. Thank you.
Aneesh, thank you so much for that absolutely fantastic discussion. Just a wonderful way to see your thought process about this patient. I'm going to invite Dr. Silverman to join us and tell us how they thought about this patient when he first came in.
Thanks, Meridale. I would like to echo your thoughts and just say what a masterful, amazing discussion of differential diagnosis in someone with a complicated recurrent cryptogenic stroke. So Aneesh, thank you so much for that. I am amazed by that and always continue to learn from you all the time. So thank you. If we go to the next slide. So next slide, please. So when we first saw the patient, we were dealing with recurrent ischemic stroke patient despite therapeutic anticoagulation. More specifically, looking at the pattern of infarcts and his encephalopathy, memory loss, other issues associated with that, we were really specifically dealing with, as you said, Aneesh, a patient with recurrent subcortical infarcts with a progressive leukoencephalopathy, which really raised our suspicion for a small vessel vasculopathy or small vessel vasculitis. So we performed a few other tests, which I think we'll go over now.
So I would like to echo what Scott said. This was a masterful differential from Dr. Singhal, and I really learned a lot as usual with his discussion. Next slide, please. So here I would like to compare two of the what came on day 7 after hospitalization. Again, we see on the upper row, we could see this white matter change up to the subcortical white matter, some progression of this abnormality. However, really you would have to compare it side by side. In the lower row, we can see multiple infarcts in the basal ganglia, periatrial white matter. And as I mentioned before, on your left lower hand, you can see in the centrum cerebrale, multiple linear areas of restricted diffusion, and almost in a pattern of a radial pattern, which is really interesting for us. Next slide, please. Here we see the progression of this patient. On your left-hand side, the admission diffusion weighted images, and on the right-hand side, day 7. And you can see that he had in hospital, he had a new restricted diffusion lesion within the deep white matter of the left occipital lobe. Next slide, please. So here I want to show you some fairly recent technique that we're using at Mass General Hospital, which is high resolution vessel wall imaging. It is called also black blood technology. And basically it's called black blood because we use a pulse sequence that actually eliminates the flow within the vessel, making it dark. And with this, you can highlight what's going on the vessel wall per se. On your left-hand side, as you can see in the arrows, you can see that there is this very circumferential avidly enhancing wall of the internal carotid artery on the left side. We can also see branches of the MCA with circumferential enhancement of the vasculature. And on your right-hand side, you can see that also the right internal carotid artery has circumferential enhancement. Now this, as we can see, when we see circumferential involvement of the vessel, this has been correlated with an inflammatory process within the wall. We know that atheromatous disease may also present with enhancement. However, this is usually eccentric. The plaque is on one side and basically the rest of the wall is completely normal. In this particular case, what we saw was a concentric enhancement guiding us more towards an inflammatory process of the vessel wall per se. Next slide.
Hi, I'm Melanie. I'm one of the neuropathology fellows. I just wanted to say thank you for having me here today. So a CSF analysis was performed, and you can see the results here. The glucose was normal, and there was a mildly elevated protein. There were some red cells, and then there was 31 nucleated cells, and the large majority of these were lymphocytes at 91% with some monocytes. Next slide, please. Then the patient was biopsied. He had a lung core biopsy as well as several mediastinal lymph nodes. And there's a picture of one of the lymph nodes here. Now, when we look at a lymph node biopsy, what we expect to see is lymphocytes and then some histiocytes, and really that's all. However, in this case here, you can see these very, very large. So if you use the red cells in the background as a comparison, the cells here are like way more, like even more than 5 times the size of a regular red cell. So they're very large and they're pleomorphic. Their nuclei are irregular and hyperchromatic. So this looks like carcinoma. Then in the staining, you can see in the smaller image that the cells are positive for TTF1, which is a marker for lung cancer, among other things. So this is consistent with a metastatic lung cancer. The next slide, please. And the final diagnosis was metastatic adenocarcinoma consistent with lung primary. In addition to the lung biopsy, the patient also had a renal biopsy. And you can see that the renal mass shown here looks like a very bland neoplasm. The cells are very monotonous looking. They all look like one another. They have a lot of this pink, slightly fluffy cytoplasm, and the nuclei are very round and very regular. On staining, it was positive for PAX8, which is a marker of renal origin. So already we know this is not a metastasis from his lung. This is actually a primary renal neoplasm. Next slide, please. Other stains were performed, and it was positive for AMCAR and CD117. And this is a little bit of an odd staining pattern, but overall, given the appearance of the mass and the AMCAR positivity, this is probably a papillary neoplasm. Next slide, please. So what we have is this low-grade papillary renal neoplasm. And the differential diagnosis here really is between a papillary adenoma or a papillary renal cell carcinoma. But on a biopsy, we can't tell because the distinction is made by size, the cutoff between the two being 1.5 centimeters. However, I guess the main take-home point here is that this is a low-grade neoplasm, and this is probably not what's causing his symptoms.
Thank you, Melanie. Next slide, please. Based on those results and other results presented earlier, and through consultation through many other services that helped us out, including hematology service, Dr. Vena's advanced general neurology service, the patient was felt to have recurrent stroke, secondary to a high probability of having a paraneoplastic CNS vasculitis. We continued the patient on anticoagulation with heparin due to the possibility of having a hypercoagulable state from malignancy. This was eventually transitioned to enoxaparin prior to discharge, and his factor 10A was therapeutic prior to discharge. He was also continued on aspirin 81 milligrams per day Risk factors were controlled with high-dose statin, anti-glycemics, antihypertensives. And as I said, and we'll discuss later, but our highest suspicion was for a paraneoplastic CNS vasculitis. We felt that we did not need to pursue a brain biopsy, that we had enough high probability. And through consultation with Dr. Vena's service, the patient was treated with high-dose methylpred, 1 gram IV for 5 days, and then was started on 60 of pred and received 1 dose of cyclophosphamide while he was admitted, with plans for future cyclophosphamide in the future. As far as his lung adenocarcinoma, the treatment was really just planning for radiation therapy. He was felt to be a poor surgical candidate, and also due to poor functional status, he was not offered chemotherapy. As far as the low-grade renal neoplasm, the plan was just to observe that. Next slide. Unfortunately, the patient went to rehab, was at Spalding, but he was readmitted to MGH 4 days later with hypoxemia. A CAT scan of his chest showed a pulmonary embolism and an enlarging left lower lobe tumor. He was started on a heparin drip on the medical service. Unfortunately, this was complicated by large volume hemoptysis. He then unfortunately developed hypoxemic respiratory failure, sepsis, developed a worsening pressor requirement, and was ultimately transferred to comfort care and passed away peacefully in the hospital. Next slide.
So an autopsy was performed. At autopsy in the brain, what we saw were infarcts of different ages. So I have 2 here. The one on the left-hand side is more recent, and you can see that it's just a solid sheet of macrophages. And then the one on the right-hand side is a little bit more remote. It has still some macrophages, but it's starting to cavitate a little bit. And then there are some reactive astrocytes highlighted by the arrow. Now, if you look at the left-hand picture, you notice that I've circled something. And what that is a blood vessel with a mural lymphocytic infiltrate. So there is some inflammation within vessels, and this one is associated with the infarct. Next slide, please. We did also see vascular inflammation in areas that were not involved by infarct. And you can see again that there are 2 pictures here. In both pictures, we are looking at a vessel, and the vessel themselves look pretty abnormal, actually. The walls are very thickened and there's a little bit of splitting going on. And then the circled area is just this very dense lymphocytic inflammation within the vessel wall. And then if you look at the white matter that is around the vessels, it's supposed to be like very, very blue on our Luxol staining, but you can see it's starting to get a bit pale and there's a lot of reactive gliosis. Next slide, please. So when we see inflammation, we like to characterize it to see what kind of cells are present. So on the left-hand slide, we have a CD3 stain that shows us T cells, and you can see that most of the inflammation is composed of T cells. The CD20 highlights B cells, and you can see that we do have a few there, but really T cell predominant overall. Next slide, please. We also stain for macrophages, and CD68 is a good marker for that. And you can see that there are scattered macrophages in the vessel wall. And then also, when you look at the areas of infarcts, you can see that the macrophages are nicely highlighted. Next slide, please. So overall, what we have here are multifocal subacute infarcts, and they are of different ages. And in association with this, we have perivascular T cell infiltrate, and the T cells were present in the areas with infarcts, but also in the areas away from the infarcts. And this is consistent with a vasculitis that has been previously treated. Now, the interesting thing about treatment is that it can really dramatically change the appearance of vasculitis, and you don't need to get a lot of steroids for that to happen. That being said, the inflammation that we see with a lot of lymphocytes is not what we see classically in primary angiitis of the CNS, but because he got steroids, we don't really know what it looked like before. Then we also did not see any involvement of the brain by metastatic carcinoma.
Thank you, Melanie. Next slide, please. So the final clinical diagnosis is paraneoplastic CNS vasculitis. This is due to the fact of his clinical picture, the radiology that was discussed, the CSF, and the pathology. As Melanie stated, although the patient did receive steroids, the pathology was not consistent with a primary angiitis of the CNS. Clinically and serologically, this was not consistent with a systemic vasculitis. The lack of tumor cell involvement and the close temporal relationship with his metastatic lung adenocarcinoma really leads us to the final diagnosis of paraneoplastic CNS vasculitis associated with metastatic lung adenocarcinoma.
Thank you so much, Scott. So thank you to all of our discussants. Congratulations to Dr. Singhal on arriving at the correct diagnosis in a very, very difficult case. Thank you to Dr. Romero for showing us the imaging, Dr. Lang-Orsini for going through the pathology, and Dr. Silverman for really sort of being the anchor for the whole case. We do have about 5 minutes for questions. So feel free to unmute and ask your question or put it in the chat. All of our discussants are available to answer any questions we have from those listening.
Thanks again, everybody. I'm relieved.
Nice to have over. Okay, Marcelo says, congratulations to Dr. Singhal and the entire team for such a brilliant diagnostic discussion on this challenging and unfortunate case. Any insight to why this manifested as a CNS rather than a systemic vasculitis process? Are there specific suspected CNS vascular antigen targets that could be overexpressed by the tumor that the patient had? Any thoughts on that from any of our discussants? Why only in the CNS and not a systemic vasculitis is this paraneoplastic phenomenon?
Well, let me start. Thank you, Marcelo, for being here during your service. You know, when we think about PACNS versus systemic vasculitis, it's the same issue. We don't know why PACNS is restricted to the central nervous system. And in this patient, without evidence of mets within the brain substance, again, we're thinking about something circulating. And I suspect that you are correct, but I'm not sure that we have any further insights. This is a rare case. And as I said earlier, there's just a smattering of patients published. So I'd leave it open to the pathologists or others to take it further.
Yeah, I don't have anything to add to that. I think that sounds very plausible, but we don't know what those antigens are.
Any other questions from the audience?
I do have a question for Aneesh. When in any of the reports that you found regarding paraneoplastic vasculitis, was the cure or the treatment of the primary tumor improve the vasculitis per se afterwards?
Good question. One would think that that should be the case, Javier. And the reports that I've reviewed, and I need to do a little more reading, I'm not sure that they had a lot of follow-up on these patients. A lot of times the cancer was metastatic and the patient succumbed to the cancer itself.
Thank you.
We have another question from Jean Latour. If someone could share their thoughts on the rationale for continuing combination anticoagulant and antiplatelet treatment, as well as the risk assessment for intracranial bleeding, giving multiple recurrences. Scott, do you want to speak to that since you were part of the treating team?
Sure, I'd be happy to. Hey, Jean, it's nice to hear from you. Yeah, I think, you know, the rationale initially, he came in on both anticoagulation and aspirin in a patient who was repetitively having stroke after stroke. We initially just didn't want to de-escalate anything. The infarcts were very small. He only had one old microhemorrhage. We felt like the risk of hemorrhagic conversion from his infarcts was very low. We ultimately decided in consultation with our hematologist to continue the current regimen for concern that there was a underlying hypercoagulable state, and it's, as was shown, he developed a PE, and continuing the aspirin, he did have significant underlying vascular risk factors as well. Yeah, it's possible that the combination ultimately, led to the hemoptysis, but we felt like that was the safest regimen at the time, and as recommended by hematology.
Thank you, Scott. So we are at time, but I wanted to just take a moment to recognize that a ton of people participated in the care of this patient, and we feel very grateful to have learned, even with a very unfortunate outcome from the patient. The hope is that everyone can learn from participating in the conference, reading this in the New England Journal, and ultimately improve the care of patients going forward. So I thank everyone for their time today, those of you who joined us, and for all of our discussants. Look for this in the New England Journal in the coming months. Thanks very much, everyone. Have a good day.
Thank you.